Welcome to the United Leukodystrophy presents Alexander disease with Dr. Waldman from CHOP.
Good afternoon and good morning to everyone. I am so delighted to participate in this family session today. You know how attached I am to all of my leukodystrophy, including my Alexander disease families. So unfortunately, we can't all be together in person, but I'm absolutely delighted to be here with you on this June Friday, no matter which time zone you're in, so that we can share some of my thoughts on Alexander disease and really give some of my insights in terms of how to treat this disorder. So I did prepare some slides for everybody, but I also wanted to make this very interactive, and I'm happy to answer any questions that you might have. I wanted to make sure that I had a chance to say, here's how I treat some of these symptoms in case they're affecting you and your loved one, but please feel free to ask questions away, and we can make this as interactive as if we were in person, or at least I hope we can. So hello to some of my friends who I see in the chat. Thank you so much for taking time to be here today. So I want to start by thanking the United Leukodystrophy Foundation, who is moderating. They are doing a fantastic job helping us with all of these online programs. It seems like there's a new one every day. I'm going to start walking through the slides, but happy to interrupt at any time to talk about things that are more important or questions that you might have. So we'll go to the next slide, please. And I just want to remind everyone about the opportunities that we've had at CHOP to learn all about Alexander disease and to meet so many of you. So as many of you know, we have two different natural history studies at CHOP where we have learned tremendous things about this disorder. And actually today I'm going to focus mostly on clinical symptoms rather than the research, because I want to make sure that I share the knowledge that we've gained with each of you, who quite honestly are an expert yourselves in Alexander disease. But I want to share you a little bit about our background. We have two studies. One we call our outcome measure study. And the purpose of this study is to explore clinical trial outcomes. We actually do spend some time, just back one slide, sorry. We actually do spend some time with you in person. We get a lot of information and data that we collect during these visits. We get clinical information and a lot of research information. We get MRIs and spinal taps if that's something that you are willing to participate in. And we do ask that families come annually to Philadelphia. I am pleased to announce that Philadelphia is now in the green phase. I know that COVID is popping up at so many other places in the country, but I do see a question, is there an idea of when we'll resume in-person research visits? We are fairly close. Right now, we are allowed to do research that is attached to clinical care. So if you are coming because you want me to see your child or yourself for a clinical visit, then of course, we're very fortunate in that our institution is not saying, well, you can't participate in research if you're already here. So if you're coming for a clinical visit, we can at this time perform a research visit as well. If you just come to visit us for research, that we will have to wait a little bit longer to be fully up and running in our research program. And many of you might see that we actually have our clinicaltrials.gov site says that we are not actively recruiting for the outcome measure study. We are recruiting for the natural history study, the one that's listed on the bottom here. The purpose of this study is to allow anyone in the world to participate. We didn't really want there to be this bias of only people who lived in our area or were able to travel easily to our area to be included. And now that everything is telemedicine with COVID, we're able to ask a lot of questions and exchange medical records through our natural history study. So a lot of different ways for you to contact our team. Everyone, I think, knows Geraldine Liu, who is a phenomenal advocate for us all and helps bring all of you to our program at CHOP. So these are the two studies that we have learned a tremendous amount about Alexander disease, and I will take you to the next slide. I just want to remind everyone that we are international. Excuse me, we've been contacted by 185 patients from around the world. Yes, of course, most of them are coming from the US, but even though I don't speak other languages, excuse me, sorry, even though I don't speak other languages, many people are fluent in English, and we have friends in many of these places who have been able to do some of the translating for us so that we can help get clinical care and research to places around the world. And then if you'll go to the next slide, about half of these patients have actually physically traveled, or a little less than half, have actually physically traveled to China to meet us. Of our friends from around the world, can I have the Perfect. Okay. I want to start, whenever we talk about Alexander disease, I want to mention that there's a lot of different phenotypes of this disorder, meaning Alexander disease affects people so differently. And there are some similarities, but there are also very vast differences in different cases. And so I think as a parent, a lot of people want to understand what this means for their child. And they might see other people online or meet them through social media or through chats like this. And people are all a little bit different. And so we think about Alexander disease in different types. For today's presentation, I'm mostly going to focus on infantile, juvenile, and adult. Of course, there is the neonatal form as well. Most of our data really comes out of infantile, juvenile, and adult cases. Other people prefer the terms type 1 and type 2, where type 1 tends to be more infantile and type 2 tends to be the juveniles and adults. For today's purpose, I am going to break them down, like I said, into the infantile, juvenile, and adult categories. And then imaging actually helps determine these different categories as well, but we're not going to talk as much about imaging today. Okay, next slide, please. All right, so I want to talk about the clinical symptoms. And as you can see here, dividing this into the infantile, juvenile, and adult, there is some overlap. For example, dysphagia, or the difficulty swallowing, which is about halfway down that slide, does affect all three groups. Whereas gross motor problems or enlarged head size is a little bit more prevalent in the younger children, the infantile. And some bladder problems are more common in the adults compared to the juveniles, but infantiles are affected in different ways as well. So there's some overlap here in between the subtypes, but sometimes people also look very differently. And what I'm going to do over the next couple of slides is tell you things that I would like you to think about in terms of treating the different symptoms associated with this disorder. Next slide. So unfortunately, I did want to include this disclaimer. So I have to say that the following slides are provided to share my multidisciplinary approach on the treatment of symptoms in Alexander disease. It doesn't mean that everyone should be on every one of these medications. There's so many other different ways to treat different symptoms. I'm happy to listen to things that have helped you or your child. So please note that this does not constitute individual medical advice, but rather talking points and strategies that I'd like you to discuss with your own doctors. Next slide. All right, first and foremost, a lot of people with Alexander disease, no matter which group you're in, have gross motor symptoms. Sometimes it's gross motor delay, and then for other people, aggression in their motor skills or balance problems. And as many of you probably know, really the core strategy to address this problem is with physical therapy. But I wanted to mention a number of different things that I really want you to mention to your physical therapist. Really, what are the goals? So of course, we want to build strength. We want to work on endurance. So, being able to take 3 steps is wonderful, but could we work towards 5 and 10 and those types of things? So how can we expand what the child's already doing? Core strength is key, right? Especially as we're trying to protect our back and our posture, as I should be sitting a little taller and straighter as I say this. But we often think so much about the legs or the arms that we forget about the core. And I was thrilled. I don't know if they're joining us, but I was thrilled that I was seeing an Alexander disease patient just a few weeks ago doing some plank work actually and yoga stretching. So hello to my friends who are doing yoga. And bracing is also important. There can be ankle braces, knee braces. We're going to talk a little bit about hand braces. So we need to really consider the physical therapist as a partner in care and address all of these different things. Tone management is also very important, and the tone issues for Alexander disease can vary. So there's hypotonia, where your tone is low, there is hypertonia where your tone is high, and then spasticity where it's mostly hypertonia and different ways to treat muscle issues. And I'm seeing some names and things popped up. I wanted to have our friends at the ULF control my slides so that I can actually look at some of the comments to make this a little bit more interactive. I will finally mention dystonia, which is more of a twisting of muscles and is treated a little bit differently than spasticity or increased tone. And as mentioned in the chat, there are some patients that actually have pain in the legs. And really the approach to there is, again, physical therapy, but then also taking some medications such as pregabalin, gabapentin. There's other medications that can help with some of the muscle pain. To our friends in the chat, sometimes you have to actually increase doses. So sometimes I would recommend starting very low with medication and then increasing it. So I would, again, I can't provide individual medical advice in a forum like this, but I do think that those medications for tone and pain and spasticity are very important, but you have to make sure that you're really balancing the side effects of the medication with what the family needs or with what the patient needs. So gabapentin and pregabalin, which could help with some pain, and I use all the time, I actually start at a very, very low dose, lower than what is recommended, very, very slowly to make sure that it's tolerated. It is safe to increase a medicine such as that very quickly, but it's not necessarily as tolerable. You get tired on it and you have some more side effects. So I go low and go slow when I'm introducing some of these medications. But I think that also brings up the excellent point that if a medication is not working, I don't want you to just give up on the medication. I want you to talk to your doctor about whether the dose could be adjusted. For example, many of us, if we have a headache, and I did this not too long ago, took a simple aspirin, 325 milligrams or whatever it is. And it didn't completely resolve my headache, but I knew that I was taking a low dose. Then later, when my headache didn't go away, I took a much higher dose and I felt much better, of a different medicine. So those are things to think about. If a medication is not working, talk to your doctor about whether the dose could be adjusted. And my recommendation is to just go slowly. We are going to, I believe, make these slides available for everyone. And then our team is also we have a physical therapist on our team. We're happy to communicate with local doctors. In fact, I think the way that things work best is if you have a local team and that we speak with your local team as partners in care, not necessarily overtaking care or making recommendations, on our own, but if we really partner with your local teams to make sure that you're getting all of the treatments that you need. Next slide, please. We are next going to talk about fine motor symptoms. And quite honestly, and it'll just give us 1 second I know it takes a few minutes for the slides to catch up. The fine motor symptoms on the next slide, a lot of those get overlooked, quite honestly. We're very focused on the gross motor symptoms. We're very focused on the speech and language symptoms in this disorder, and I'll come to that in a second. But many of us actually skip over some of the fine motor skills, but these are so important to our everyday lives. So our eating, writing, caring for ourselves, brushing our teeth, brushing our hair, as mine continues to get in the way here. Those are things that we do on a daily basis. So occupational therapy is also incredibly important. We want to work on dexterity, handwriting, and it's not that your child or you have to write a word, but just being able to communicate, use an iPad. There are some really good things about iPads, even though I'm anti them right now with my children and being on quarantine. We also want to make sure that we're keeping the hands, trying to make sure I'm centered here, as open as possible. So if your hands are like this all the time and they start to get stiff, we want to just make sure that we're able to open them. And sometimes we brace patients at night so that they're not like this when they sleep. Oops, sorry, trying not to block my face. So they're not like this when they sleep and we can relax their hands. So bracing becomes important too. We can't forget to think about the tremors. I work with different medications for tremors, but if you're having a tremor, it's hard to eat. And there are some different tools and things that we can recommend to help with a tremor, so it's a little bit more comfortable for you to eat or to write or to do other things that you need to do. And the next slide, please. All right, I want to talk about speech and language pathology. So a speech therapist, most of us think about those type of individuals as those that help with receptive language, expressive language, and of course, nonverbal communication. You know, we're very fortunate in Alexander disease that our children and adults seem to understand very well. They understand what we're asking of them and what we're saying to them. Sometimes they have trouble expressing themselves, and they might not actually be verbal, but they're able to communicate, and they're able to communicate through, you know, using a touch device or other things. And so we want you to have a speech and language pathologist to help with your diction or your pronunciation, as well as your ability to communicate. In addition to that, there are other roles of a speech and language pathologist. So a lot of speech and language pathologists actually conduct swallow evaluations. So in our program, we have a wonderful speech and language pathologist that does a clinical evaluation where she will watch you or your child eat. She will look at all of the mechanisms of the swallow, and I could not believe how complicated a swallow actually was in terms of the different muscles that contribute to it. But she will watch for safety, and she will give advice on how to modify to make sure that oral feeding is safe and efficient for you or your child. We get so much of our pleasure from eating. Our social structure revolves around eating and that family meal. So we want to make sure that this is as safe as possible. There are some programs that rely on a video swallow study with barium, or even a fiber optic swallow study, and those are needed from time to time to give us more information. Please do remember that there's sometimes, if you can't handle your saliva and you can't swallow it normally, that you might be aspirating. It might be going into the lungs. That can cause a pneumonia. It can cause a lot of other challenges. We want to make sure that we are addressing any silent or overt aspiration. Clinically silent, meaning you or your child are not coughing, and of course, overt aspiration, where you're actually choking while you're eating. And there are some different strategies to make oral feeding safer. You know, smaller bites, pacing the meal, doing some thickened liquids. You know, there's a number of different strategies, and we can work with you and your family to make sure that this is not burdensome for you. I have a child myself who is a difficult, picky eater, and, you know, mealtime should not be difficult. So these are all things, or stressful. Mealtime should not be stressful. These are all things that we would help you work on. Next slide, please. Some of the other symptoms, such as seizures. So, and I apologize that some of the writing is a little bit small, but, you know, seizures come in a couple different patterns. So there are focal seizures, which start in one part of the brain, and then more generalized seizures that affect the entire brain simultaneously. So the whole brain starts to change at once. And then there's some people who are doing are doing well in between seizures, but they have changes on their EEG or their brainwave tests. And depending on your team and your physician, we treat some of these things a little bit differently. But as many of you know, medication is really our first line for seizure management. And I put a few medications here that I just wanted to mention. So many children are started on Keppra first and foremost, and Keppra works very well in our Alexander disease patients. As some of you may know, you can get a little cranky on Keppra, and Briviact is a newer form, not often approved by insurance, but has a little bit less irritability, so might be a little bit more tolerable. As many people know, I actually like the medication Depakote or Depakine for seizures. It treats many different symptoms of Alexander disease, and seizures being one of them. Now, Depakote does have a lot of side effects and things that need to be monitored. So as a neurologist, it's not really the first drug I choose outside of Alexander disease, but as you'll see in a few minutes, it actually treats many of the different symptoms of Alexander disease. So it's actually a helpful drug in that you can actually treat 4 or 5 different symptoms of this disorder with one medication. But you actually need a local team that is aware of all the side effects of Depakote, knows what to look for, and knows what to monitor. So it does require blood work, it does require monitoring, so it becomes a little bit more complicated than using Keppra or levetiracetam. I will mention trileptal. It's also a favorite of mine. I use it all the time as a general neurologist. I do feel that in Alexander disease, sometimes there's a little more fatigue with trileptal or oxcarbazepine compared to, say, levetiracetam. So it's safe to use. It just sometimes causes a little bit more, few more side effects, as I'm stumbling over my words there. But the good news is that there's plenty of different seizure meds. And so there's lots of different choices. And so working with your local team in terms of what medication might be best for you. The key thing to remember is on the bottom of this slide. It's not so much what medication you're on, but that you do have a seizure action plan. You do, if indicated, take a medication regularly, that you have a rescue medication or a rescue medication plan, and that you're making annual adjustments for weight based on my rule of thumb that for every 5 pounds you gain, you got to increase the dose. Otherwise, one last thing before we move to the next slide. So as you might remember from a few slides back, seizures are not present in every individual. If you have not had a seizure, it is not automatically required that you go on a seizure medication, but I will sometimes at least discuss a seizure rescue or medication in case a seizure were to occur. But fortunately, a lot of our older Alexander disease patients, the juveniles, adults, or type 2, they don't have as many seizures as the infantile patients, so they don't necessarily need these drugs, but sometimes you'll see in a minute, I put them on Depakote anyway because it's a good drug for other symptoms of Alexander disease. All right, we'll go to the next slide. And we're going to talk next about vomiting. So this is a big one. And a lot of people don't think to ask me about it because I'm a neurologist. I'm not a pediatrician. I'm not a GI doctor. But we've learned that this is actually a very common symptom in Alexander disease. And there's a lot of different mechanisms or why this might be. So first of all, there's brain involvement of the area postrema, or the area in the brain that controls vomiting. The second reason there's vomiting in Alexander disease is that there's a lot of reflux. So in the muscles in this area, our swallow and our esophagus tend to be a little bit weaker, lower tone. And reflux is when the stomach contents come back up and they irritate the esophagus. They sometimes get into the lungs if it's severe enough. And so there's a lot of different, you have brain issues, you have muscle issues, and there's a lot of reason that vomiting occurs. And what's also interesting and debated as terms of what it means is there is gut GFAP, or the glial fibrillary acidic protein. So we think of the GFAP always in the brain, and we don't think about it as being elsewhere in the body, but it actually is in the gut as well. And we don't know what it does there, but I have some hypotheses that maybe it causes some inflammation in the gut. And that's why some of our friends who try a gluten-free diet actually tend to see improvements in vomiting because they're no longer eating some inflammatory foods that might be contributing. So the other thing with vomiting is you always have to make sure you're looking from below. So make sure there's no constipation, as constipation can affect the gut. If you get backed up, there's nowhere for the food to go, and up it comes. So I will treat vomiting first and foremost with reflux medication. So omeprazole, lansoprazole, famotidine are just examples of what we use. And I really want, they're so easy and so benign that I just make sure that this is not being, the reflux from the stomach acid is not really what's triggering some of the vomiting. The other thing that I do, as many of you probably know, is Depakote. So as we mentioned, this medicine, but it's a seizure medicine, so it works in the brain, meaning it works on this brain involvement in Alexander disease, the brain mechanism that causes vomiting. So Depakote actually works incredibly well, not only for seizures, but for vomiting as well. And many of you also know that I used to use a lot of steroids for Alexander disease, and I used to use a lot of steroids to treat the vomiting, and those also work very well, except steroids have a lot of side effects. They affect your bones, they affect other things. Now, Depakote has its side effects too, but I've been very pleased that I've been able to get patients off of steroids and onto Depakote pretty successfully and stop their vomiting. And now we're even talking about weaning it in some of our patients, which is nice. We do sometimes use medications that are used for anorexia or other things in cancer. That's sort of my third or fourth line medication that I use. And we already talked about some dietary modifications that might be appropriate for you or your family. So a lot of things that we can do for the vomiting, and I hope that many of you think about approaching your doctors about some of these possibilities. All right, next slide, please. And I'm looking at, okay, bowel and bladder symptoms. And I am just going to, I see some questions in the chat there, and I am just going to take a picture of that so that I have that email address, and I will circle back later. Okay, so bowel and bladder symptoms. As we mentioned, constipation is a big factor that can contribute to vomiting, but constipation is very uncomfortable, and we certainly don't want people just sitting on the toilet or caregivers having to even disimpact family members. It's obviously poop is poop, right? So we want to get it out, but we want to make it soft and easy on everyone. So we want regular soft stools, and we want to also prevent overflow incontinence. So what happens if you have a large poop that is stuck, then sometimes you will spill around the poop, and that also is very unpleasant, where you start to have bowel leakage, and we don't want that as well. So we treat this with many different methods. First of all, we do recommend some dietary modifications, increased fiber, increased water. There's lots of different things. I didn't list them all here. But I do have to admit that I myself have some picky eaters that don't eat their fruits and vegetables and, you know, the way that they should. And to get a 3-year-old or even sometimes a 30-year-old to eat all of their fruits and vegetables is not always the easiest. So we do recommend some other strategies where we have people, what I say, clean out from below. So think about a clogged sink. Okay, if the sink is clogged and you're just adding more water, nothing's going to work. So you can add all the Miralax you want. If you're not cleaned out from below, the Miralax is not going to do as much as it could or should. So I will sometimes recommend suppositories or enemas. Please work with your local teams, your local physician, your pediatrician, or your primary care physician to ask if these strategies are appropriate for you. And then sometimes we do treatment from above. Once we know that people are cleaned out, then we will sometimes use any of the strategies listed here to try to have regular stools to prevent constipation from recurring. Next slide, please. And so one of the reasons constipation is so important is because it does also impact the bladder health. So we want to make sure that there aren't urinary tract infections, that we are going to the bathroom regularly. I do understand that, of course, not all of our patients have control of their bladder, but constipation will affect the urine, it will cause the urine to just sit, and then the urine becomes stagnant, and then more bacteria grow. So make sure that you or your child are emptying their bladder regularly. There are some foods that actually irritate the bladder that we would recommend you avoid, and treat constipation as well. Next slide. And sleep. All right, sleep is critical for all of our health. For you, your loved one, everyone needs good sleep. And sleep can be interrupted by a lot of different things. So there's medications that interrupt sleep, anxiety and worrying, whether it's recognized or not. Some of us sit there and say, why can't I sleep? And then realize that we were thinking about something that kept us awake. And then sleep apnea, which of course is the major symptom in Alexander disease for adults, but also children, that can interrupt sleep. So my advice is for everyone to practice good sleep hygiene, limit electronics. They're evil. I mean, they're necessary evil, but they can be evil. Please stick to a schedule as much as you can. And what I mean is know your own pattern. So I personally, just because of adulthood and responsibilities, I'm a morning person. I'm used to getting up and going. It's probably from all those early rounds in the hospital, whereas other members of my family are more night owls, right? And so if being a morning person, if I stay up till, 11 or 12 at night, I'm still going to be up at 5, 6 in the morning because my biologic clock is set in that way. So staying up late doesn't mean I get to sleep in. My body says, okay, it's time to get up, even if I want to sleep. On the flip side, if someone's a night owl, no matter how much melatonin you pour into them, probably not going to get more sleep. Hopefully they will get some. But you have to know, are you more of a night owl or a morning person? Is your child more of a night owl or a morning person? I can't tell you how many parents think, well, they'll stay up late, but they'll just sleep later. Doesn't happen. Our bodies are on a rhythm. So it doesn't mean that you can't actually ever stay up late or get up early. You just can't do it several days in a row. So know your patterns, work with your patterns. If you're a night owl, work at night. If you're a morning person, do your work in the morning. Same thing for schooling. As children might study better at night or early in the morning. And with COVID, everyone's schedule is just completely disrupted. But when it comes to sleep apnea, please bring up to your doctor if you have loud snoring, the kind of snoring that family members hear down the hall, or if you have pauses during your sleep. These are dangerous symptoms of Alexander disease. They may require a sleep study or BiPAP, called bilevel positive airway pressure, or CPAP, continuous positive airway pressure. So talk to your doctor about your sleep patterns and your goals. I think most of us have a goal of getting a lot of sleep. All right, next slide, please. All right, I'm just going to have I only have a few more slides left because I wanted to make this a little bit more interactive where you could ask me questions instead of me just talking the whole time. Whoops, it says my battery's running low. Got to figure out which charger. Well, that's not, I have like 10 chargers down here. Of course, the one thing I forgot to do before we got started here is plug it in. All right, so one thing to talk about is the Global Leukodystrophy Initiative. All right, hold on. I'm not able to get my charger and talk at the same time. I don't even know if this is plugged in. Give me 1 second. I'm sorry, guys. I thought I was still on top of things, plugging in early. Okay. I think that's plugged in now. Perfect. All right. So I wanted to share some good, exciting news with our U.S. Community in that the Global Leukodystrophy Initiative Clinical Trials Network is funded by the NIH. And even though a lot of research right now has been changed because of our inability to do a lot of in-person visits, we're still moving forward with a lot of different things we're collecting through this initiative. So the goal here is to collect data on about 300, here it says 280 rare diseases, but over 300 different patients with Alexander disease, but with other diseases as well, all within the leukodystrophy family. And we're going to follow them serially. And we're thrilled that Alexander disease is part of this initiative. Next slide, please. In fact, there are a few projects within this initiative, and I'm thrilled that one of the projects is actually dedicated to Alexander disease. So the NIH is supporting us, and we couldn't be more grateful. And I actually have to acknowledge the United Leukodystrophy Foundation, who gave us the support to get the preliminary data to get this NIH grant. So I got chills while saying that. We're so grateful to the ULF and of course to the NIH to be doing research in Alexander disease. It's incredible. It's a wonderful experience, and it would not have happened without the patient community. If you hadn't come to CHOP, we would have no information to share. So thank you for calling, emailing, and visiting us. And because of you, we now have these additional funded studies. Next slide, please. So what this means is some of you, when you come to CHOP, you might see some different outcome measures that we do, or even some shorter evaluations, which might be nice for everyone because those days at CHOP are quite long when you come to visit us. But at least in the US, we also have all of these other now collaborating sites. So I will just go through them quickly. Everyone knows us at CHOP. There's also Dr. Fatimi at Kennedy Krieger, which is in Baltimore, Maryland. Florian Eichler, who is at Harvard Partners in Boston. Jamie Power, who's at Children's National Medical Center in Washington, D.C. Yeah, there are a lot of leukodystrophy experts on the Eastern Seaboard here. But Keith Van Haren is in Stanford, so closer for our California friends. Stephanie Keller at CHOA in Atlanta in Georgia, Abigail Collins in Denver, Lisa Emmerich at Texas Children's Hospital, and Josh Bonkowski at the University of Utah. So these are all leukodystrophy experts that are also going to be participating in this initiative, seeing Alexander disease patients, doing a similar evaluation to what we do at CHOP, where they would do some physical therapy, speech, cognitive measures. There's a battery of tests that everyone has, just like at CHOP. And they also are doing spinal taps and MRIs as we do at CHOP. So in this era of COVID, when it's not possible to make your way across the country or halfway across the country, at least this gives some of our families some more options in terms of how to continue to participate in our Alexander disease natural history study specifically. And next slide, please. So what can you do? Well, I want everyone to make sure that they're building their own medical village around you, your loved one. And what I mean by this is make sure you're keeping track of everyone who's on your team. So make sure you have annual visits at least with your pediatrician or your primary care physician. Make sure that you are checking in regularly with a gastroenterologist, nutritionist, pulmonologist, physiatrist, so a rehab doctor to really focus on the tone management and Botox and things of that nature. Physical therapist, occupational therapist, speech and language pathologist, social worker, and care coordinator. So build your own team. Recruit the best people that you can. I'm happy to always be your coach, but I need a local team that we can help work with. The other thing is, please know your insurance benefits. Maybe you can get a case manager to help you with insurance. Insurances are always very complicated. I find them very frustrating, but you also need to think about some hidden fees with insurance. So for example, there's a different cost sometimes if you have labs done at CHOP versus if you have labs done at Quest or LabCorp or some of your local patients. So great question coming through. Or your local sites that I sorry for that misspeak. Can additional sites be added to the study such as UVA? Wonderful question. So the NIH has sponsored this GLIA network of sites. If we can maybe go back 1 or 2 slides to that list of sites. Yes, great. Okay. And 1 forward to the list of different sites. So these are the sites that are funded by the NIH. And what do I mean by this? It's very difficult if, for example, if you go to UVA for a spinal tap for Alexander disease, if it's done through research, there's a very different set of rules than if it's done for clinical care. And as you can imagine, a spinal tap, for example, might not be the thing that every Alexander disease patient needs, and it's done through the research program. So UVA couldn't be added at this point because this is funded by the NIH. This is a very, very, very costly grant. I'm thrilled that there are 9 centers. I do recognize that there's so many other wonderful leukodystrophy centers beyond these 9 centers. So I would suggest a couple of things. So you can always participate in our studies remotely. You don't necessarily need to do everything that is done for every patient by coming to CHOP. That's number 1. Number 2, if you can participate at one of these sites, I would recommend that for the research. But number 3, I also am happy. I know lots of people at UVA. And yes, you're correct. There is lots of research done at UVA. The challenge, though, is that research takes contracts and funding and a lot of things. So you can't just pick up somebody's, it's kind of like picking up somebody's recipe book, but not having any of the ingredients in the house. You can't just make the recipe, even though you have the steps and you know what to do. You have to buy the ingredients. There's a cost associated with some of these tests. And so it's not as easy. However, our team would like to make it as easy as possible. So for example, if you are having a spinal tap or an MRI, you could collect that information and share it with us, and we can enroll you in our program, even if you're not physically coming to see us. So there's lots of things that we want to do. The worst thing, I think, would be to disengage people that can't come to one of these sites. The goal of this program was actually to spread expertise to other sites, not necessarily spread our expertise, but acknowledge the expertise of all these different sites. Just unfortunately with budgets and funding, there was only so many sites that could be included. But if you're having a procedure done at a site that's not listed here, please let us know. If we have enough time in advance, we might be able to work with your site to either collect samples or to collect information, or if it's something that they would have done clinically, we might be able to use that information as well. So please don't think that you are not important to us if you're not able to travel to one of these sites. And if we go to the next slide, I will show you why. Okay, so what can you do? So first of all, for the clinical side, I want you to build your own team. I want you to understand, who is on your team, and I want you to understand your insurance benefits. As for the hidden fees for lab fees and hospital bills, as I was mentioning, it always surprises me when I take my daughter for some routine blood work and then I get this high bill in the mail that I just wasn't thinking. CHOP, for example, is more expensive could be more expensive than LabCorp and Quest. And so you might choose to go to one of those sites because your fees might be much less. Or for my friend from UVA, it might make more sense to get blood work done at UVA where that is in your insurance network, rather than having that blood work done at CHOP. And there are ways that we can sometimes have people send blood work from different places in the US. It does take some coordinating, but we've done it before. On the flip side, some people say, you know what, I want an experienced pediatric person to draw my child's blood. And so sometimes they choose to have it done at CHOP, but you should really understand what the price differences might be. Same thing for hospital bills. It never ceases to amaze me where there's a physician bill for some things and then a hospital bill for some things, and you think you paid everything off and then you get another bill in the mail. So know your insurance and know what fees might apply. And getting to the research side, how do you become a research advocate for your child or for yourself? Regularly check for updates on clinicaltrials.gov. That is the US database for any clinical trial. And so for example, you can look at the two studies that are, the first one being our outcome measure study. I just listed there the number for our natural history study on Alexander disease. And underneath, the Myelin Disorders Biorepository Project, which is really the overarching CHOP central data point for the GLIA, the NIH grant that I just mentioned. And I agree, it is so important to have that right care team and many players on it. Okay, so for the next slide, I just have to acknowledge we do have a big village at CHOP for our medical team. Many of you will recognize a lot of these faces, sorry. And these are all the people that are interacting with you and your loved ones regularly. And there's a lot of people not even on these slides, and the next slide as well. I just have to thank so many people, first and foremost, patients and their families, for everything that you've done to share your family, your knowledge, and your expertise with us. And I will take questions for the remainder. Are there symptoms of the ears from Alexander disease? I think that's what the question is. That's a great question. So yeah, there can be a lot of dizziness or balance issues, not so much ear pain. Ear pain is more of a headache variant than a primary symptom in Alexander disease. And headaches in Alexander disease don't usually manifest here. They're usually here or in the front. So there's more dizziness and balance, I think, if that's what you're asking about, related to Alexander disease. And so those strategies include hydration. There's sometimes medications that we will use. And we also really employ physical therapy to really train our families in terms of how to walk safely. And I'm happy to make this interactive and take as many other questions as I possibly can. I'm hoping everyone is safe and well. Such a challenging time for our patients and our community. I do hope everyone is practicing social distancing and wearing a mask, no matter where you are in the world. Please protect yourself and your loved ones. All right, so I know that there are, actually, maybe I'll spend a few more minutes also talking about different places from around the world. So I did, and I was waiting for that question. I just saw it pop up. I'll get to it in 1 second. So there are people from around the world that we have collaborated with. So even though I included the US sites, please know that we have lots of collaborators, and I'm probably going to forget somewhere, but we have collaborators in the UK, in Amsterdam, in Germany, France, Spain, Italy, Israel, of course, South America. So we got many in Argentina. Thank you to all my Argentina and South American friends. I didn't make it to Chile or Brazil 2 years ago when I was fortunate enough to visit, but we have teams down there. Australia. I'm trying to think of where else I go. Of course, Canada. So even though a lot of what I talked about today was US based, there are plenty of our collaborators throughout the world that are dedicated to Alexander disease as well. Okay, so the $1 million question, which I think everyone was waiting for. So what year can we expect the Ionis clinical trial to start? You know, I'm not going to actually give you an exact time, but let me say this. So I am pleased to share that there is in fact a timeline of when the clinical trial will start. We are not prepared to share it in case there is a detour with the plan, but there's lots of information. Now I'm stumbling over my words. So there is a timeline, there's a plan, everything is moving forward at a warped speed. There is one more sort of stop-go checkpoint that does not have to do with the safety of the medication. There's no concerns there. So we are moving full speed ahead. And we hope to have more information as soon as possible that we will broadly share with the community. Everyone knows that we are going to be shouting from the rooftops when we are ready to go. And I want to thank Ionis tremendously. I know they're not on the call today, but I want to thank Ionis tremendously for their efforts, for their commitment to ending this disorder, for thinking broadly about our patient population, and for their commitment to bringing this to trial. So we are close. Please hang in there. You know that as soon as we're ready to go, we will announce everything as broadly as we possibly can. All right. Lots of questions, and I apologize that there's issues with language. I think pain is continuing to be a common symptom. So I think that with pain, we need to think about where the pain is coming from. Is it coming from the head? Is it coming from the muscles? Is it coming from nerves? Those are all treated a little bit differently. So there's lots of different strategies. Sometimes it's medicines to relax muscles if the pain is coming from muscle spasms. Whereas if it's a headache, many of my friends will know that I also put patients on medications to lower their pressure. Depakote also treats headaches. You know, I talk about Depakote all the time as a medication that helps so many different symptoms. And so I do see that there's some requests from the chat from some international patients having some trouble with language, and I apologize for that. And I don't speak Portuguese or Spanish, but we will figure out how to make sure that your questions are met. We have, just watching our time, we have about 13 more minutes. What other questions might everyone have? We'll see if any more continue to pop through. I know this is a different format for all of us this year as we're trying to navigate the way to present everything broadly and yet interact at the same time. So these chat features are helpful, but I know they also sometimes slow down as you're trying to get information there. There also is a question, although it's in Spanish, so I'm not sure that I'm going to be able to interpret that one. What I also see is all of us become relaxed a little bit in our medical care, and I'm no different, right? So I have a slew of things that I'm supposed to be doing for my medical care for myself, most of which I'm pretty far behind on or not doing as regularly as I should. But just as we are supposed to take care of ourselves with regular doctor visits, regular dental visits, sleep and exercise, we need to think about doing the same thing. So make a list of the doctors that you need to see regularly. Make sure you're seeing those, you're keeping those appointments. And then the question becomes, why do I need to see the doctor if I'm feeling well? Well, you know what? There always is the opportunity to tweak or to check in or to make sure everything's okay. And if everything's going well, it'll be a quick visit for you, but you've established care. You're on that doctor's forefront, the forefront of their mind, which is very important too. You know, let's say you have an issue with vomiting and you go see your doctor regularly. They might say, you know what, I do have a new medicine. Let's try something else. So there's lots of different opportunities. Okay, so more questions coming in. Have you already finalized acceptance criteria for patients for the clinical trials? So just to reiterate, I don't get to choose. It is really up to Ionis to decide who to enroll in the clinical trial. They mentioned several years ago a point, and I will just repeat that the goal for a clinical trial is actually to treat the fewest number of individuals to show that the treatment works. I know that that was a difficult thing to hear a couple of years ago when it was presented at the Alexander Disease Family Meeting in Wisconsin. But the goal of the clinical trial is to make sure that the drug actually works before broadly giving it to a number of patients. What I can say in addition to that is I'm very fortunate to be working with Ionis because they actually are thinking as broadly as they possibly can. And so even though they want to treat just the exact right number of patients to show the drug works, I am very relieved that they are thinking very openly as they can about which patients to treat. So they are trying to design a clinical trial to be available to as many patients as possible, even though the goal is actually the opposite, and to show that the drug works in as few patients as possible, because you want to make sure that it's, of course, safe before you give it broadly. So they are working on finalizing the criteria. I do not have a copy of those final criteria, and I can't share them, once they're given to me, but we are very close. I think there's a couple more questions about the clinical trial. So I will actually, maybe at the close, have the ULF team ask if there's any other Alexander disease specific things at this trial. I actually saw some wonderful things on the docket for tomorrow, I think, about just pulmonary function and just other symptom management, which I think is incredibly important. So there's lots of other symptom presentations that I think will be very helpful. Thank you to all the support for everyone. And there's a question about some shaking of the leg. So clonus, when your leg goes like this, well, that of course interrupts your ability to walk. It can sometimes be uncomfortable. It can sometimes be painful. In those cases, we do use medications like baclofen, physical therapy, and again, bracing and positioning. So making sure sometimes that you have a brace for the leg so it can't move as much, working with a physical therapist, a physiatrist, so a rehabilitation physician, and a neurologist on medications, physical therapy, and equipment. So make sure you're thinking about all of those things. I do believe too, and I do hope that at the end, maybe Tara will share with us that this will be available online. I know that there is some trouble sometimes with translating, and maybe people can watch it a little bit more slowly so that I talk fast and maybe they can get a little more information from the website. I do believe it'll be available at the beginning of July on the ulf.org. I think the point, a couple of closing points, we still have 8 minutes, so please keep your questions coming, is I want to make sure that our international families understand that there are lots of experts at many places in the world on Alexander disease, not just here in the US. And we're happy, the ULF, I'm sure, and myself, we're happy to make sure that you can connect with as many people from around the world as possible. I didn't mention Asia before, but I do think that there's a collaborator, I believe in Japan, who is a phenomenal publisher and has written a lot on Alexander disease. So please know that there are places around the world that you can get similar care, and that we're happy to provide any advice. We can't provide direct medical advice to people that we have not seen. And so that's not as, if that is not ideal, like we have to actually be your care provider in order to provide medical guidance, but we can work with your local teams and say, well, you know what, we tried this, this, and this, maybe, consider trying one of those strategies for your child. The other thing that's wonderful news is the ULF is going to have closed captions on the website videos. So hopefully that will help. As you can see some of the writing, you can see me stumbling over my words, and then you can maybe use your translating services as well to try to get more information that way. And yes, families, you can do your annual visit in Atlanta at CHOA, given that they are one of the GLIA sites, rather than coming all the way to CHOP. And so we know that travel is incredibly difficult right now for everybody. Safety is our #1 priority. We want everyone to be healthy. We want you to be safe. Traveling for an annual visit is not a top priority. If there's clinical care that you need, of course, we'd be happy to see you and want to make sure you're getting the best clinical care. So do not lapse on your clinical appointments. So if you have been holed up for the last several months at home because of COVID anywhere in the world, please don't skip out on your appointments. See if your doctor will do a telemedicine visit. In different states, we're able to do telemedicine. Unfortunately, in Pennsylvania, we're not able to do telemedicine past July 30th, or June 30th, excuse me, June 30th in other states. So we are now seeing telemedicine only for Pennsylvania and where I'm also licensed in New Jersey. But I'm happy to talk to any of your primary care doctors, pediatricians, and internists to make sure that you get the clinical care that you need. So maybe they're offering a telemedicine visit if you're not able to leave your home to go to have an appointment. So we have just 5 minutes remaining. My goodness, this time flies by. Oh, thank you from everyone in Argentina. I miss you guys. It was such an incredible experience, life-changing for me to be able to come and see you. To some of my other international friends, I had hoped to travel this year to the UK and Israel. Those travel plans obviously did not pan out, but I do hope that we are able to travel to many of the other places around the world, not just in the US. Yes, the dizziness. Okay, so there's a question again about dizziness, severe dizziness when in the car or being pushed in a wheelchair, and then the sensitivity to light. So a couple of different strategies. I do use a medication called Zofran, Ondansetron. I have to say I haven't had a tremendous amount of success in the car with it. I will use it because it's quite benign. I try that for dizziness. I do use Depakote. Everyone knows I use Depakote for everything. It seems to be a good medication pretty broadly. Steroids sometimes help, but they have a lot of side effects. And with the bright light, that one's a little bit tricky too. Sometimes special glasses or wearing a hat or a visor are some of the non-medication things that we will try. So lots of different strategies. I'm just going to write down some of my friends who are asking for me that I can kind of call to talk to you guys about some of these different things. Well, thank you so much. I do appreciate that. I'm glad that you found this helpful and informative. Just a reminder of us all to be taking care of ourselves and taking care of our families at this time. Making some notes. Does anybody else have any other questions that I can answer for them? To some of the participants who, of course, I know very well that are reaching out about some specific questions, please know that I'm not going to be able to answer you today. I do have actually a packed afternoon with a couple different commitments. So I might not be able to get back to you today, but I will reach out to you next week to answer some of your questions. And if I forget, please send me an email through our MyChop system or let me know, and then we can circle back on some of the challenges that you're having. And then to the international patient, I took a picture of your contact, so we will figure out a time to connect. I hope that's helpful. All right, in just a minute, I think we're going to wrap up. Oh, one more question that I do think I might have missed. Oh, great question. Are there additional medications or treatments being researched now for Alexander disease outside of the clinical trial medication? Not as much in a formal way. There's maybe some ideas that are floating at the earlier stages and some strategies that other people are thinking about to maybe use in the future. But formal medications that would go to a clinical trial, right now, the antisense therapy is the only thing that is this close to patients and being in the clinical space. So lots of other ideas. lots of other long-term strategies that everyone is considering and trying to think about how it would be employed and how we would bring it to trial, but probably several more years away from those types of trials. Well, thanks everyone. I think I'll turn it back over to Tara for any closing remarks. It was wonderful to be able to see everyone, or at least your names. Please stay well, stay safe. Thank you to the United Leukodystrophy Foundation. Please look for this to be available on ulf.org, and let us know if there's any way that we can help your family.